Hi, I'm Dr. Maggie Redfield from the Mayo Clinic, and I'm here today to talk about the RELAX trial, which was the phosphodiesterase type 5 inhibition therapy to improve exercise capacity and clinical status in diastolic heart failure trial. This trial was performed in the Heart Failure Clinical Research Network, which is a National Heart and Lung and Blood Institute-sponsored consortium of investigators who design and conduct clinical trials. So why did we do the RELAX trial? Well, diastolic heart failure is very common. Heart failure is very common, and half of heart failure occurs in people who have a preserved ejection fraction, but all the signs and symptoms and morbidity that we see in heart failure when the ejection fraction is reduced. So it's a critical need area. And to date, there have been no effective therapies developed for this condition. So that's why we did it. Why did we choose PDE5 inhibitors? As you know, PDE5 inhibitors are of benefit in patients with erectile dysfunction, and they help because they improve flow-mediated vasodilatation, or endothelial function. They're also approved for the treatment of a rare disease called Group 1 pulmonary arterial hypertension, and they help in that condition because they dilate the pulmonary vasculature. We also chose that drug because there were some key preclinical studies in animal models where PDE5 inhibitor therapy improved left ventricular remodeling, improved ventricular structure and function, and improved vascular function and renal function. And there have been a couple of very small single-center clinical studies in patients with heart failure and reduced EF that suggested this therapy improved exercise capacity. And one study in patients with heart failure and preserved EF, or diastolic heart failure, that didn't look at exercise capacity but showed a lot of other beneficial effects. So that's why we did this trial. How did we do it? Well, we wanted to make sure we chose patients who really had the syndrome. So patients had to have New York Heart Association class 2 to 4 heart failure symptoms, an ejection fraction that was greater than 50%, and they had to have objective evidence of heart failure. And that could be either a heart failure hospitalization, or they could have had catheterization, documented high filling pressures at a study done for evaluation of dyspnea, or they could have diastolic dysfunction at echo in the setting of chronic diuretic therapy. Plus, at study entry, they had to have severely reduced exercise capacity on a cardiopulmonary exercise test, and they had to have a high level of BNP, or at least if their BNP was low, they had to have previously been documented to have high filling pressures at the time the BNP was low. So that was our study designed to select the patients. They underwent a large battery of tests, the cardiopulmonary exercise test, 6-minute walk test, echo. If they were in sinus rhythm, they had an MRI, and they had biomarkers and heart failure questionnaire scores. They were then randomized to either placebo or sildenafil at 20 milligrams 3 times a day. That's the dose that was shown to be a benefit in patients with pulmonary arterial hypertension. They came back after 12 weeks, had some repeat studies, and then the dose was increased to 60 milligrams TID. That's the dose that was shown to be of benefit in some of those other human studies in heart failure. They completed another 12 weeks of therapy and had repeat baseline studies. We were powered to detect a pretty small improvement in exercise capacity, and the primary endpoint was the change in peak oxygen consumption at cardiopulmonary exercise tests. So what did we find? Unfortunately, we found a pretty consistent message that this therapy was not of benefit in patients with diastolic heart failure. The change in peak VO2 was not significantly different between the two groups. Change in 6-minute walk distance was also not significantly different. We did a kind of a clinical status score. That was not different. Minnesota Living with Heart Failure questionnaire, the change in that was not different. We looked at a number of parameters of cardiovascular structure and function at echo and MRI. No difference in the change in LV mass, no difference in the change in diastolic function as ascertained by E to E prime, an echo measure of filling pressures, or even in pulmonary artery pressures, which you would think it would change based on the pulmonary arterial hypertension literature. There was really no change in biomarkers of heart failure severity, no difference in many of those. However, there was a significant difference in renal function between the two groups. Patients treated with sildenafil experienced more worsening of renal function. It wasn't dramatic, but it was statistically significant. And it was associated with increases in BNP, endothelin, and uric acid. So based on this study, unfortunately, we conclude that this therapy really doesn't have a signal of benefit in this condition. We feel quite strongly we really got a good population. They were elderly, they were obese, they were 50% female, they had severely limited exercise capacity, marked evidence of diastolic dysfunction and high filling pressures. So we think we got the right population. Unfortunately, it doesn't look like this is the right drug for diastolic heart failure.